Hello friends, welcome to my YouTube channel TNC Updates, Toxicology and Critical Care. Before starting today's topic, let me issue the disclaimer. The following video touches various important topics of critical care medicine and toxicology. The videos are not exhaustive account of the disease conditions discussed. The videos derive their content from various standard textbooks of medicine, critical care, toxicology. But as the guidelines change rapidly as per the new level of evidence, the viewers are strictly advised to follow the discretion and advice of treating specialists. Today's topic is very important. It concerns every doctor. The topic is antimicrobial therapy in the ICU. The backbone of modern ICU. Apart from reducing mortality due to infectious diseases, the unparalleled discovery of these magic bullets has enabled us to perform complex and invasive surgeries, organ and stem cell transplants, administer immunosuppressive therapies for neoplastic autoimmune conditions, and subject critically ill patients to life-saving procedures like mechanical ventilation and intravascular device placements. All this was not imaginable even without antibiotics. There are two scenarios when we give antibiotics: empirical and targeted. So let us talk about both. Empirical antimicrobial therapy. Empirical antimicrobial therapy must be discouraged in clinically stable ICU patients in whom thorough evaluation of fever or suspected infection is warranted prior to starting antibiotics. Example is just see viral fevers, dengue, chikungunya. So you are having viral fevers and you start with antibiotics, it's totally wrong. But there may be other scenarios where you may not have the symptoms, but patient may be having the infection. So the host factors, for example, clinical signs other than fever may be absent in profoundly neutropenic patients who is too immunosuppressed to mount an inflammatory response to infection. By and large, opportunistic bacterial and viral illnesses have an acute onset compared to fungal and parasitic infections, which may have subacute to chronic course in these patients. So, what are the risk factors for drug resistant pathogens? History of healthcare contact. Antimicrobials in the past 3 months, that is 90 days. So up to 90 days, once you give the antibiotics have an effect in the body. Surgery or invasive procedures, hemodialysis, presence of indwelling devices, prosthetic joints are some of the accepted risk factors. Out of all the factors, receipt of antimicrobials in the past 3 months is considered the strongest risk factor for multi-drug resistant pathogens. So we have to be very careful when we give antibiotics because it itself will become a risk factor for MDR pathogens in future. Antimicrobials must be based on syndrome and not on severity. For example, septic shock due to community-acquired pneumonia or UTI does not warrant use of carbapenems in the absence of risk factors for MDR infection. I have seen a lot number of times that the patient is having severe infection and they start with meropenem. Patient is having high counts, start with meropenem. Although the patient is directly coming from a community, he is having no history of any hospital admission. So in that case, putting higher rung of antibiotics like carbapenems just on the basis of clinical symptoms, that he is having severe symptoms, or just on the basis of laboratory that he is having more of TLC DLC, that is absolutely wrong. So you have to see the syndrome from where the patient is coming. You have to see the host factors, whether he is having any comorbidities, having exposure to antibiotics before, having other conditions like prosthetic devices, etc. Then you have to choose the antibiotic. So, just an example, reviewing the syndrome. A young nature enthusiast was transferred from a nursing home with a diagnosis of cerebral malaria on the basis of rapid malarial antigen test positive for Plasmodium vivax. Despite completing a course of IV artesunate prior to admission, he presented with fever, shock, seizures, and encephalitis. Multiple peripheral smears for malarial parasites were negative. History of fever that began 1 week after returning from forest trek and identification of the pathognomonic eschar in the patient's groin clinched the diagnosis of scrub typhus. He was treated successfully with doxycycline for 7 days. So history is very important. The syndrome as a whole is very important. Don't read the investigations. Identifying and controlling the source of infection. Every attempt should be made, even in unstable patients, to achieve source control through minimally invasive bedside procedures, such as ultrasound guided pigtail drainage of a post surgical collection for both diagnostic and therapeutic success. Antibiotic selection and dosing in critical illness. The systemic exposure to a drug based on its absorption, distribution, metabolism, and excretion is termed as pharmacokinetics and pharmacodynamics. Pharmacodynamics describes the mechanism of action of the drug with respect to the biochemical and physiological response that the drug exerts in the body. So you have two things: pharmacokinetics, that is absorption, distribution, and metabolism, excretion, and pharmacodynamics is how the drug is acting with respect to the host factors. Unlike other pharmacological agents, anti-infective, the antimicrobials, the antibiotics, pharmacokinetics, and pharmacodynamics is unique. Why it is unique? Because owing to its effects on the infective pathogen, the host, as well as collateral impact on the microbiome. So antibiotics don't only affect the pathogen, they also affect the microbiome in our body. There are many other useful bacteria in the body. There are many other bacteria in the body which are commensals, which are affected by the antibiotics, and it changes everything. The need for non-toxic but higher doses of antimicrobials in order to destroy non-mammalian target sites, and the relentless battle against emergence of resistance over time are the most significant pharmacokinetics pharmacodynamic challenges associated with anti-infective agents. So antibiotics, that is sepsis you are having. So what is happening in sepsis? Basically it is capillary leak, third space fluid losses, hypoalbuminemia. So all this results in increased volume of distribution. You are also giving fluids whenever the patient is having low BP, you are resuscitating. So increased volume of distribution. So when the volume of distribution increases, fluid retention occurs, you go on to the RRT. You think of hemodialysis, you think of decreasing the fluids. Then there is a self compensatory mechanism in the body, augmented renal clearance, which I have talked in my earlier presentation about acute kidney injury. You can go through that presentation. What is augmented renal clearance? So it is a self compensatory mechanism in which there is increased clearance by the body itself. Sepsis in itself causes renal hypoperfusion, acute tubular necrosis, which causes acute kidney injury resulting in reduced clearance. Again, you will think of hemodialysis or ECMO. Then another very specific condition of sepsis is that you are having a lot of lines, devices in the body, especially in ICU patients. Then you have biofilms. If the patient is having some prosthetic devices, prosthetic implants, then that they get infected, then they are very difficult to treat because they form a film on that device that is not easily penetratable. So there is increased minimal inhibitory concentration of the organism present there. So there is altered pharmacokinetics, pharmacodynamics of antibiotics in that situation. Diverse host factors uh, alter pharmacokinetics pharmacodynamics in septic patients. Hence, the practice of protocolized antimicrobial dosing in the ICU has fallen out of favor with an emphasis now on individualized therapy with a pivotal focus on applying PKPD knowledge at the bedside. So, one term is very important, that is MIC. What it is? The minimum inhibitory concentration for 50% or 90% of all isolates of a bacterial species, that is MIC 50 or MIC 90, and the inhibitory or effective concentration for 50% of all isolates of virus are considered the conventional standards used to describe drug activity against pathogens. In simple terms, they are lowest concentration of a drug required to inhibit visible growth in vitro in test tube. So, MIC concentrations are given by the laboratory. This chart tells us many things. So, y-axis has drug concentration, x-axis has time. So, the uh, breakpoint is the highest concentration, the critical concentration of antibiotic at which you see that the bacteria are susceptible to the antibiotic. So this is the point above which the antibiotic is affected. So on this chart we have breakpoint, we have MIC 50, MIC 90, we have mutation prevention concentration, and we have minimum bactericidal concentration. So these 1, 2, 3, 4 and 5 points are very important. So 5 points, if we see on the y-axis, what they tell, this is the minimal concentration, that is a break point. So at this level, so if the antibiotic is effective, that is the break point has occurred, that the bacteria are susceptible. MIC 50 or 90 is that it is visible in, it is phenotypically visible. The lab will give what value? MIC. MIC tells us the minimal concentration that is inhibitory for 50% to 90% of all isolates of a particular bacteria. And MIC, above MIC, we have mutation prevention concentration, that is concentration above the MIC required to prevent the development of resistant mutations, to prevent the development of multi-drug resistant organisms. And what is MBC? That is the minimal bactericidal concentration. It is the lowest concentration required to kill 99.9% of the initial inoculum of pathogens. We will come back again to this diagram once we analyze the actual report given to us in the hospital of the culture sensitivity. So this is same minimum bactericidal concentration, lowest concentration at or above the MIC required to kill 99.9% of the inoculum of the given organism. Antimicrobials are considered bactericidal if the MBC is no more than 4 times the MIC. So if the difference is less between MIC and MBC, that means the drug is bactericidal. If the difference is more than 4 times, then the drug is bacteriostatic. All these in vitro parameters are extremely important as standard epidemiological tools that govern the PK principles. But in vivo environment, they are fraught with limitations. They don't take into account factors like interaction of the immune system with the drug, effect of antimicrobial combinations used in critically ill patients, the post-antibiotic effects, persistent suppression of bacterial growth even after the concentration of the drug at the site has decreased below the MIC. So, synergism and antagonism. What is synergism? Synergism in simple terms is that 2 plus 2 is not equal to 4. It can be equal to 5, it can be equal to 6. So this is not told by the lab. So this is stored by the human body, the immune mechanism, the host factors. Sum of activities of the agents used in combination is greater than the individual activity of the agents if used alone. So anti-tubercular treatment is an example, HIV antiretroviral treatment, treatment of MRSA prosthetic walls, endocarditis. So there we combine vancomycin with gentamicin recommended for bactericidal killing. And addition of rifampicin is done in very unique cases for the antibiofilm property in the presence of a prosthetic valve. So antagonism example, zidovudine and ganciclovir. So whenever we talk of antibiotics, we start with the loading dose. What it is? It is product of volume of distribution and desired plasma concentration. So you just imagine human body as a bucket. So bucket has a certain volume and you are going to put in that bucket a certain drug. So after putting that drug, the drug will achieve a certain concentration in the bucket. So how do you measure how much drug you are going to give? If you know the volume of the bucket and you multiply it with the concentration. So loading dose is volume multiplied by concentration. You can also derive volume is equal to loading dose divided by concentration. So it is a product of volume of distribution and desired plasma concentration. Renal function plays no role in the calculation of a loading dose. So it is a very common mistake being done that whenever we give the loading dose, say meropenem, polymyxin, or we are giving colistin, in those cases, loading dose, you are not going to take into account the renal functions. But maintenance dose, yes, you will take into account the renal function. For hydrophilic drugs such as beta-lactams and glycopeptides like vancomycin and teicoplanin, the volume of distribution is usually small, but in sepsis, this may be increased because there is third space losses. Thus, a high loading dose. So the volume of bucket has increased. So volume of bucket has increased in sepsis, but the concentration we want the same. So volume of bucket has increased, concentration we want the same. So loading dose will be on the higher side. Thus, a high loading dose is optimal for patients in sepsis. The second critical factor, that is plasma concentration, is based on MIC. But with empirical therapy, MIC is given by whom? MIC is given by lab. So in empirical therapy, MIC we don't know beforehand. Thus, a high initial dose is recommended for both concentration dependent antibiotics for maximal bactericidal effect and time dependent antibiotics to ensure adequate tissue penetration. So, antibiotics divided according to PK, PD into two broad categories, concentration dependent and time dependent antibiotics. So let's come to the maintenance dose. Depends on the mode of action of the drug as well as individual patient factors that influence its PK-PD interactions. The benefit of prolonged beta-lactam infusions to improve outcome in critically ill patients has been validated in various studies. But keep in mind that prolonged infusions alone result in lower peak drug concentrations. For example, CLSI, so all MIC values are given by standard labs. So these there are two labs, one is CLSI and one is UCAST. CLSI stands for Clinical and Laboratory Standard Institute and UCAST stands for European Committee of Analysis and Susceptibility Testing, as I will tell you later. So, for example, CLSI resistant breakpoint for meropenem is 4 microgram per ml for Klebsiella pneumoniae. But if meropenem breakpoint for a carbapenem resistant Klebsiella isolates is more than 16 mics per ml, prolonging the infusion of carbapenem may be counterproductive as it may prevent the drug from achieving concentration above the MIC and hence diminish bacterial killing. So let us illustrate this with the help of chart. It will be more easily understood. So whenever we give antibiotic, we are giving it in two ways. One is that we are giving, say, 8 hourly, and the other way is that we are giving in an infusion. When we are giving in some fixed period after a fixed interval of time, so the antibiotic concentration goes up, it achieves a certain peak, then it comes down. So it is a pendulum. It is swing high, then comes down, then again. So it is coming up and down. But whenever we give it in an infusion, it it achieves a certain level and it stays here. So this is time, this is concentration. There are two ways of giving antibiotics. One is this way, that is up and down, that we are giving up and down, and second is antibiotics being given in infusions like this. So the question is that how much time above the MIC. See, this is the MIC, minimum inhibitory concentration. So the level in the blood, the concentration of the drug in the blood, the time it stays the above MIC is important. So in this case, when we are giving after fixed intervals, this much period of time it stays above MIC. So this is 40% T more than MIC. When we are giving in an infusion, it is 100% time is above the MIC because it's always staying above the MIC. So you will say that this is better, that infusion is better. But one thing is missing. This infusion doesn't achieve this peak. You can see this peak which is achieved uh, the way when we give it in after fixed periods. So when we are giving after 8 hours, after 6 hours, the drug achieves a certain peak. So this peak is not achieved when we are giving the drug in infusion. So this peak is very important. If the MIC of the drug has gone above a certain level, then by infusion, if we are giving, then this will not be achieved. So it will not be effective. But infusion definitely is helpful in especially in patients who are very critically ill. So infusions should be reserved for patients who are critically ill. So dosing strategies based on PK/PD. So concentration dependent drugs and time dependent drugs. Which are the concentration dependent antibiotics? Aminoglycosides, metronidazole, amphotericin B, echinocandins. PK/PD targets maximum concentration Cmax by MIC. So what is the dosing inference? High dose, extended interval, or even once. So amikacin you give once daily in a renal compromised patient, or even in normal patient you can give once daily dose. So increase the interval to 48 hours, say in a renal compromised patient. So toxicity in a concentration dependent antibiotic relates to the TRO. So it is relating to the how much time the drug stays at the trough level and not peak concentration. Less frequent dosing supported by post antibiotic effect. So less frequent dosing will have less post antibiotic effects. In time dependent antibiotics, which are the time dependent? Beta lactams, macrolides, so erythromycin class, clindamycin, tetracycline, aztreonam, linezolid. So many of these antibiotics are also in the area under curve. Area under curve is the combination of these two. Polymyxins, fluoroquinolones, tetracyclines, vancomycin, teicoplanin, tigecycline, linezolid. So they are both time dependent and area under curve. So time above MIC is important. Maximum bactericidal effect is usually achieved at 3 to 4 times the MIC with a beta lactam concentration above the MIC for 40 to 70% of the dosing interval. High loading dose followed by frequent maintenance doses. So that is the dosing inference. Benefits of extended infusion considered in patients with high Apache scores, high volume of distribution, augmented renal clearance, and high organism burden. So who are these patients? Infusions are to be given in very critically ill patients. Otherwise, the uh, high loading dose followed by frequent maintenance dose is okay. Loading dose may be essential prior to extended infusions. Whenever we use even extended infusions, loading dose is very important to ensure rapid antimicrobial action, especially in pharmacologically protected sites such as CNS, bone, and joints. So, meningitis patient, osteomyelitis patients, they require very high doses. Area under curve by MIC. Area under curve takes both antimicrobial concentration and time into account. High doses plus frequent dosing intervals target AUC by MIC ratios to be achieved for greater efficacy. For example, it's more than 400 for vancomycin. So this is just an example to make you all understand what is happening in the ICUs and the hospitals. This is the usual report: culture and sensitivity, aerobic tracheal secretions. Conventional aerobic culture, it is the method uses Vitek 2. So organism given is Acinetobacter baumannii. It is a carbapenemase producer. So let us see. So what is the meaning of these words? See, MIC has been given. So if you see, cefoperazone sulbactam is intermediate and MIC reported is 32. Let's see meropenem. Meropenem, which is it is a carbapenemase producer. So meropenem should be resistant, and MIC is more than equal to 16. Piperacin tazobactam resistant. So sensitivity is there for minocycline, ceftriaxone EDTA sulbactam, and tigecycline. So the footnote says ceftriaxone EDTA sulbactam is available, but evidence is not sufficient for its use. There are no breakpoints from FDA, CLSI, and UCAST. Pharmacokinetic, pharmacodynamic safety, hypocalcemia due to EDTA chelation are some of the limitations. So along with this, there is attachment. This is the attachment which is always tagged in the culture sensitivity. So sensitivity breakpoints. So this is the breakpoint. If you see the same meropenem, the breakpoint is less than equal to 2. It has used. It can be 4, it can be 2. With respect to every organism and the antibiotic, it can differ. So there is a combination of antibiotic and an organism. So antibiotic and an organism gives you the breakpoint and the MIC values. So in this case, Acinetobacter, which was isolated in this tracheal secretion report, the breakpoint is 2 and the uh, MIC was what? MIC was more than 16. So if the MIC is more than the breakpoint, as we saw in the previous charts, the breakpoint is the uh, bottom line. So it is the maximum concentration above which the drug is effective at a therapeutic level. So if the MIC is less than the breakpoint, it is sensitive. But if it is more, if the MIC is more, then it will be reported as resistance. This I find very useful. Whenever we talk of infections in ICU and hospitals, it is always written, but no one reads it. So I put it a separate slide because this is very important. Strict hand hygiene. Ensure that 5 moments of hand hygiene are followed. PPEs where required, and patient placement in isolation room if it is required. Cohorting can be followed by placing patients with similar infection together in same corner of the ward. So if you are having same type of patients, same type of, say, you are having a ventilator associated pneumonia, place them together, don't place them with the other patients. This is called cohorting. So ensure a spatial separation of at least 3 feet distance between beds with privacy curtains in between. Single-use patient dedicated equipment such as BP cuffs, stethoscopes, nebulizers, etc. should be used. Patient transfer, infection controls measure should be followed even during transfer. These are very important. This will prevent a lot of infections. Analysis of culture sensitivity reports. So whenever we see those culture sensitivity reports, how do you analyze those reports? The zone diameters or MICs of one antibiotic can't be compared with zone diameter or MIC of another antibiotic. It is a common erroneous practice to choose antibiotic with the lowest MIC value on the culture report. MIC value is specific for a given antimicrobial in relation to the microorganism isolated. However, it can't be interpreted based on this absolute value alone and must be interpreted in relation to its breakpoint. So you can't say that meropenem is having less MIC than imipenem or another antibiotic. You can't compare one MIC with MIC of another antibiotic. You have to compare the MIC with respect to the organism, and you have to see whether it is less than the breakpoint. The breakpoint highest plasma concentration that can be achieved safely and defines whether an organism is susceptible or resistant to the drug. So it is the defining point for susceptibility or resistance. Clinical breakpoint values are predetermined by CLSI and UCAS, European Union Committee on Antimicrobial Susceptibility Testing. There are several phenotypic antimicrobial susceptibility testing platforms. Disk diffusion methods, macro and micro dilution methods, automated methods such as VITEC, microscan, mass spectrometry methods, several molecular genotypic PCR based platforms. These are the upcoming new things which are in the ICUs and hospitals. Everything is based on biogenetics now. So we are having PCR based platforms which are very quick to give the reports. We will analyze them in the end with some examples. While interpreting a culture report, bear in mind the following points. Susceptibility testing is an in vitro phenomenon. So it's in the test tube what is happening. For serious deep-seated infections such as infective endocarditis, meningitis, osteomyelitis, endophthalmitis, implant-related infections, severe sepsis, and infections in immunocompromised hosts. Testing by determination of MIC is a must. Drug susceptibility by MIC is mandatory for certain organisms and antimicrobials for which there is no established disk diffusion criteria, vancomycin, teicoplanin, raptomycin, staphylococcus species. Susceptibility of polymyxins for all gram-negative bacteria should be based on MICs by broth microdilution technique only. So this was there in the culture sensitivity report: susceptible, intermediate, resistant. What does this mean? Susceptible means MIC is less than breakpoint of a given organism. Intermediate means MIC is very close to or equal to breakpoint. Resistance means MIC is greater than the breakpoint. So it is unlikely to be effective. So antibiogram is very important for blood isolates. Let us see, in a typical ICU, we are having two types of patients. We are having patients coming directly from the community. We are having patients from coming from other parts of the hospital. So community acquired is that within 48 hours of admission, the patient is having a diagnosis of infection. And hospital associated, we will say that patient has passed more than 48 hours and he's not responding, or he's having an infection, then it can be an hospital associated infection. See, community acquired infection, again we divide into three categories depending upon the host factors. Type 1 is low risk, moderate risk, and the type 3 is high risk. Type 1, the low risk, which is the low risk community acquired infections: no healthcare contact, no antibiotics in last 90 days, no comorbid conditions. Which are the common organisms here in low risk community acquired? Mostly in the community we have streptococcal like throat infections, E. coli infections, Klebsiella pneumoniae infections. Here we, what are the resistance rate? See here, the extended spectrum beta lactamase rate is 33%. Carbapenemase resistance, Enterobacteriaceae, no, there is nil. Vancomycin resistant Enterobacteriaceae nil. Methicillin resistant Staph aureus nil. So ESBL, extended spectrum beta lactamase, we are having in the community in the mild infection also. So whenever you are starting with antibiotics, you have to cover for a community acquired infection, you have to take care that 33% patients do have now ESBL also. Type 2, that is moderate risk. Here, what is moderate risk? Contact with healthcare, uh, contact with a healthcare antibiotics hospital antibiotics in last 90 days. He has already received, or there are less than two comorbid conditions. So organisms E. coli, Salmonella, Staph aureus, Enterococcus. So here ESBL increases, but carbapenem and vancomycin resistance is still not there. MRSA appears. So methicillin resistant Staph aureus is 50% in moderate risk community acquired. Type 3 is high risk community acquired. Here the patient has hospitalization in the last 90 days with some invasive procedure device, more than two antibiotics within the 90 days, more than two comorbidities. Organism E. coli, Klebsiella, Acinetobacter here appears. Staph aureus. So here we are having, this is a high risk community acquired, we are having ESBL, here we have CRE. So carbapenem resistant appears in the category 3 of community acquired. So carbapenemase resistance is now coming into the community, and that is in the third category, third high risk category. So vancomycin still not there, MRSA is there. Hospital associated, that is type, we don't have in the hospital associated the mild category. So patient is already more than 48 hours of admission are there. So we don't have, we start with the moderate risk and go on to the high risk. Contact with healthcare, antibiotics in last 90 days, less than two comorbid conditions. So organisms are E. coli, Acinetobacter, Salmonella, Enterococcus. So here we have ESBL and MRSA. But type 3, hospitalization last 90, invasive procedure device, more than two antibiotics in less than 90 days, or more than two comorbidities. So Klebsiella, Pseudomonas, E. coli, Candida, Enterococcus, Enterobacter, ESBL, CRE, VRE, MRSA. So all the harmful organisms are there, and we have a candida also. So it's very common practice these days putting antifungals everywhere. So antifungals are to be only for the type 3 high risk category. Don't use in these patients the antifungals. Why my ICU is different? ICU is a different part of the hospital. Why is it so? Although an integral part of a larger functioning hospital, it is unique. Prolonged illness, greater morbidity, use of indwelling devices, mechanical ventilation, burden of broad spectrum antibiotics creates an ideal sanctuary for microorganisms with resistance patterns which are uncommon in other areas of the hospital. As a result, unit-based antibiograms specific to the ICU have been shown to have substantially different antibiotic susceptibility patterns as compared to hospital-wide antibiograms. So, whenever you are receiving these culture sensitivity reports, you get so many things positive. You don't know whether I should treat it or whether I should not. So, colonization versus infection. It's very important to understand this. What is colonization? Host microbe association with growth and multiplication of the microbe, but without tissue invasion or damage, does not result in sufficient tissue damage to cause clinical illness. Infection is host microbe association that results in clinical symptoms and signs of disease or radiological, microbiological, or histopathological evidence of invasion, inflammation, and tissue reaction. Pathogenesis, usually harmless commensals, may be protective against invading pathogens, may invade under certain circumstances, breach of skin, mucosa, immunosuppression. Infection, invasive, host tissue destruction. Organism usually identified from non-sterile swabs. tracheal aspirates, drains, urinary catheters. They may not be the true pathogens if repeatedly isolated. They may be true pathogens if we are repeatedly isolating them. Some protected specimens, brushings, or colony counts are above a specified limits. So in these patients where the colonization, what is the role of treatment? Usually none. Source control, if you are having candida in the urine samples, remove the catheter. If you are having source control in presence of device and catheter, you need not treat them. So organism isolated from sterile sites, blood, CSF, ultrasound या CT guided aspirates, surgical specimens. So here you need the antimicrobials. So how do you separate wheat from calf? That is important. A patient who has either received multiple antibiotics for prolonged periods, has no compatible syndrome, or has an alternative explanation for the clinical signs and symptoms is likely to be colonized rather than truly infected. So example is Candida species, frequently isolated from urine, sputum, tracheal secretion, bowel specimen, especially in antibiotic treated patients, and are almost colonizers. This fungal colonization is best considered as a risk factor for candidemia rather than the disease itself. On the other hand, isolation of the same organism from the urine of a neutropenic host or a patient due to undergo urological instrumentation warrants prompt treatment. Blood cultures detect bacteremia in only about half of the patients with clinically suspected sepsis. The positivity rate much lower in the presence of ongoing antibiotic therapy. Nevertheless, a positive blood culture is considered an alarm bell that warrants immediate antimicrobials and source control. Isolation of coagulase negative Staph aureus from single blood culture sample usually represents contamination by skin colonizers. Thus, in patients with intravascular access devices, prosthetic valves, pacemakers, orthopedic implants, simultaneous paired cultures should be repeated from intravascular central catheters and percutaneously to differentiate colonization from true infection. So let us summarize it in a chart form. You are having a positive culture report, and there are two scenarios. You are having a positive culture report in an asymptomatic patient. You are having a positive culture report in a symptomatic patient. So asymptomatic patient, you are having a positive culture control. There can be inadequate infection control, precautions for specimen collection, transport, skin colonizer, lab contaminant. So no treatment required, obviously. Asymptomatic patient, you are having the collection was okay, but the patient is also okay, then you have to go for source control, that is adequate, catheter removal, etc. Treatment not required. Asymptomatic patient, now asymptomatic because he is not able to mount a immune response, so these are severely immunocompromised, unable to mount inflammatory response, for example abscess formation, you have to consider treatment. So treatment only in one of the case. Symptomatic patient, so you get an organism is not consistent with clinical syndrome, site of infection, for example candida from tracheal and urine culture. So you are not having candida in blood, but you are having in tracheal and urine culture, and patient is in septic shock. So you have to look for true pathogen. Organism isolated from sterile site, consistent with clinical syndrome, and immune status of the host. Everything is matching. So treat as per the drug susceptibility. Whenever you start antibiotics, always start thinking about de-escalation. De-escalation principles and myths. It may be described as discontinuation of one or more components of an empirically prescribed antibiotic combination, or the change from broad spectrum to narrow spectrum antimicrobial. What are the anticipated benefits? Decrease in antibiotic related adverse events and superinfections. For example, Clostridium difficile infection or superinfection due to selection of resistant bacteria. It reduces your cost. overall antimicrobial consumption is directly proportional to antimicrobial resistance. So you have to reduce it. So on day 3, when you are getting the culture sensitivity reports, mostly say day 3 or day 4, you think of de-escalation. So there can be two scenarios. One scenario is that on day 3, 4, your patient is improving. On day 3, 4, your patient is not improving. So how do you proceed in both the situations? With de-escalation. My patient is improving. What I do with the de-escalation? So clinical improvement, labs are improving, so cultures have come, culture sensitivity has come, there's opportunity for de-escalation, de-escalate. If cultures are negative, continue same and reassess for de-escalation daily. So other scenario, clinical assessment doesn't support infection. The patient doesn't have an infection. Labs are okay. Initial labs are also okay. Initial labs means CBC, CRP, procalcitonin, radiology. Everything is okay. Microbiology, gram staining, everything is okay. Cultures also coming negative. Stop the antibiotics. So if the patient doesn't have anything, not the clinical syndrome, nor the labs, you stop. If the patient having the clinical improvement, labs improving, cultures sensitivity gives you an opportunity to de-escalate, de-escalate. If cultures are negative but your patients are improving, you continue same. If patient is not improving, clinical worsening, your labs are also worsening. So cultures positive or negative doesn't matter. You have to escalate the treatment. You have to attempt source control. You have to repeat the cultures. You have to consider some alternative diagnosis. Your patient is not improving. Cultures are positive but covered by empirical treatment. So cultures are positive and it is also covered, but the patient is not improving. So then you have to escalate again. Broaden antimicrobial cover. If isolated organism unlikely to be true pathogen. Source control. Repeat cultures. So drawbacks and challenges in de-escalation. De-escalation is done on the assumption that short courses of empirical antibiotics have little impact on development of antimicrobial resistance. So you think I'll start with ampicillin, Gramoseph, it won't have any impact. It is wrong. Recent research has clearly shown that antimicrobial resistance can appear within the very first few days of treatment. Hence, the strategy of de-escalation can't be used as a crutch for indiscriminate prescription of broad-spectrum antibiotics to all patients who present with fever in the ICU. So fever can be because of some connective tissue disorders. Fever can be because of viral infections. So if it's not an emergency, don't start the antibiotics. So best de-escalation is don't start the antibiotics, and second best de-escalation is stop the antibiotics completely, as we will see later. De-escalation invariably involves use of more than one antibiotic, either as an initial combination therapy or serially during a step-down approach. It has been considered that two antibiotics may cause more harm than one. The principles of de-escalation from broad spectrum to narrow may not be applicable in all situations. For example, when empirical treatment with meropenem is de-escalated to ciprofloxacin for a susceptible Pseudomonas infection, this may be considered as narrowing of the spectrum, but the patient is exposed to two courses of short duration antibiotic therapy, each with a different and potentially cumulative damaging effect on the microbiome. De-escalation has been found to be associated with an increase in the total duration of antimicrobial therapy. There is a false perception that narrow spectrum antibiotics are harmless and can be continued for long periods. So once the culture sensitivity report comes, you continue that antibiotics for such a long time. The most optimal strategy for de-escalation begins with adequate source control where applicable, followed by timely discontinuation of antibiotics after they have served their purpose. So these are the stewardship, antibiotic stewardship. So all the things have been summarized in chart form. I will go to the next slide. Antimicrobial resistance, a gloomy picture. India's antibiotic use has more than doubled in the last 1 decade, giving it the dubious distinction of the world's largest consumer of antibiotics. Our rates of antimicrobial resistance are equally alarming, with carbapenem resistance seen in up to 50% of hospital-acquired Klebsiella species and more than 70% of hospital-acquired Acinetobacter species. The increasing prevalence of azole-resistant Candida auris in ICUs across the country, with some reporting it as a predominant isolate, serves as a grim reflection of the many potential fallouts of unregulated widespread use of broad-spectrum antibiotics in our country. Antimicrobial resistance mechanisms and their clinical applications. Two types of resistance broadly, how they acquire: intrinsic resistance and acquired resistance. Intrinsic resistance, chromosomally mediated, where the antibiotic is inherently resistant to a particular microorganisms. For example, polymyxins and the new beta-lactamase inhibitor, that is a ceftazidime, avibactam, have broad activity against drug-resistant drug-resistant gram-negative isolates, but they have no anaerobic activity, and this must be kept in mind when selecting empirical cover for intra-abdominal sepsis or other sites with likely anaerobic infections. Acquired resistance, it is a highly efficient process whereby a resistance trait is transferred horizontally from one bacterium to other. Plasmids are small circular double-stranded DNA molecules that can be transferred from one bacterium to another, even between bacteria of different species. So they employed these strategies encoded on these plasmids. So they were how the resistance is developed. There are different mechanisms. One can be reduced cell wall permeability, enzyme modification to inactivate the antibiotics, drug target site alteration. They don't combine with the drugs. So once other can be efflux pumps that remove antibiotics. Once they come in, they can be pumped out. So intrinsic resistance pattern of common pathogens. So whenever you have to remember this list is very important. So whenever you say having culture sensitivity reports, you are getting Acinetobacter species. When you are having Acinetobacter species, don't think of these antibiotics alone. So Acinetobacter will not be sensitive to these antibiotics. So it is intrinsically resistant antibiotics. Ertapenem, ampicillin, amoxicillin, fosfomycin, ceftazidime, avibactam combination. When you think of Enterococcus, don't think of cephalosporins, fluoroquinolones, macrolides, trimethoprim sulfur, methoxazole, clindamycin, ertapenem. When you think of enrobes, when you're thinking anaerobic infections, abdominal infections, don't think of polymyxins, don't think of gentamicin, don't think of ceftazidime, think of metronidazole, think of dalacin. So when you are having bacteria from Enterobacteriaceae family, Proteus, Providentia, Serratia, Magnella, Burkholderia, Salmonella, so don't think of polymyxins. Polymyxins will not work in this situation. When you are thinking of getting Trichosporon, Cryptococcus, Histoplasma capsulatum, Mucorales, don't think of Caspofungin and Mycofungins. So be careful when you are selecting the antibiotics. These are the very common organisms, very notorious organisms, which everyone knows. I'll given it the short form of escape: Enterococcus faecium, Staphylococcus aureus, Klebsiella pneumoniae, Acinetobacter baumannii, Pseudomonas aeruginosa, and Enterobacteriaceae. So everyone encounters these organisms in the culture sensitivity reports seen every day in our hospitals. So they are notorious in terms of they are not responding to our antibiotics. They are so let us start with the Enterococcus faecium. Multi-drug resistant Enterococcus species, both intrinsic and acquired resistance seen. They are relatively resistant to all penicillin or penicillins. So altered penicillin binding proteins, that is PBP, are the prime drivers of resistance in Enterococcus faecium, resulting in high levels of resistance to beta-lactams. Enzymatic degradation is implicated in aminoglycoside resistance. However, although they are resistant, penicillin doesn't act, but synergism is generally seen when aminoglycosides are combined with a cell wall active agent, and this bactericidal combination has been the standard of care for enterococcal endocarditis. However, certain enzymatic modifications and ribosomal mutations have led to high levels of aminoglycoside resistance, resulting in loss of expected synergism between gentamicin or streptomycin and a cell wall active agent such as penicillin or vancomycin. Changes in peptidoglycan synthesis results in high-level vancomycin-resistant enterococci. Different vancomycin-resistant clusters result in varying resistant levels and phenotypes. Resistance is variable to vancomycin and teichoplanins. So next is staph MRSA. The property of methicillin resistance in Staph aureus is chromosomally mediated, so it is not acquired. The bacterium must possess the MAC-A gene, which encodes for a structural change in penicillin binding protein. This will prevent beta-lactam antibiotics from binding to cell wall. This type of resistance cannot be selected by antibiotic pressure on a methicillin susceptible Staph aureus during treatment. So antibiotics won't result in this type of resistance. It is chromosomally inherited. Methicillin susceptible Staph aureus isolates with variable resistance to vancomycin have been reported. So it can be intermediate or totally resistant. These are possibly selected by prolonged exposure to suboptimal concentrations of vancomycin. So it's very important to use the appropriate dose. So next is the Enterobacteriaceae. So Enterobacteriaceae, very common group of gram-negative roots that commonly inhabit the human intestinal genitourinary tract. They are widely found in environment, water, soil, sewage, everywhere. They are an important cause of drug-resistant community in our hospitals. Common members are Klebsiella species, E. coli, Enterobacter, Proteus, Serratia, Citrobacter, Salmonella, Shigella. Resistance among this group is generally acquired. So it is acquired through production of beta-lactamase. So it is by plasmids. So there are three types: beta-lactamases, extended spectrum beta-lactamase, and carbapenemase. So these are the details. Beta-lactamase, these enzymes split the amide bond of the beta-lactam ring. These can be encoded by chromosomal genes or more commonly by transferable genes. Extended spectrum, they are heterogeneous group of enzymes that confer resistance to most beta-lactam antibiotics including penicillin, cephalosporins, monobactam, aztreonams. They retain, so ESBL is also effective against monobactams, but ESBLs, they retain susceptibility to cefamycin, cefoxitin, cefotetin, cefmetazole. Also, they retain susceptibility to carbapenems and beta-lactamase inhibitors such as sulbactam and tazobactam. So, ESBL organisms are susceptible to carbapenems and they are susceptible to beta-lactamase inhibitors plus susceptible to cefamycins. This is important during clinical applications. Carbapenemase, which is getting very common now, confer resistance to most beta-lactam antibiotics, including carbapenems. This mechanism is distinct from other mechanisms of resistance exhibited by carbapenems, such as impaired permeability due to pore channel mutations and efflux. So these beta-lactamases have been divided by Ambler into four categories: penicillinases, carbapenemases, cephalosporinases, and oxacillinases. So this classification was based on their molecular structure. Knowledge of this classification finds clinical applicability in early optimization or de-escalation of antibiotics based on rapid detection of resistance genes on molecular detection platforms. So we are having now molecular detection platforms in our ICUs and hospitals that I was talking earlier. Everything is now based on biogenetics. So all these enzymes which we were talking about in Enterobacteriaceae class, beta lactamases or ESBLs or carbapenemases, these enzymes are there because of some genes from genetic changes. So these genetic changes are picked by various molecular detection platforms in our hospitals by various PCR based tests. So those tests tell us that which enzyme is present, and from that we infer which antibiotic is to be used. These are very helpful and they are in almost quick time, very quick time. So let us give an example. A hemodynamically unstable patient with ventilator-associated pneumonia is found to have a carbapenem-resistant Enterobacteriaceae on tracheal culture. Empirically started on, as in most of the hospitals, started on teicoplanin, meropenem, and polymyxin B. Then an expert carba R or rapid cartridge-based PCR is performed on a sample which detects OXA48 carbapenemase gene with a turnaround time of 1 hour. The intensivist stops all the ongoing medication and rapidly optimizes the treatment to ceftazidime avibactam, which will be effective against this carbapenemase and achieve superior lung concentration as compared to polymyxin B, thus sparing additional carbapenem use. On the other hand, if the same patient's expert carba R detects New Delhi metallo-beta lactamase carbapenemase gene, that is the class 2 of Ambler classification, those genes are detected, then a polymyxin based combination therapy, preferably with the carbapenem, may be used. But if the carbapenem MIC in the culture sensitivity is more than 16 milligram per liter or 16 microgram per ml for the given isolate, then other drugs like TIGI or phospho can be combined with poly-B. It must be kept in mind that all MBLs, metallo-beta-lactamase, confer resistance to all beta-lactam type antibiotics. So whenever you have MBL antibiotics, then all beta-lactam antibiotics are ineffective except monobactams, aztreonam, and the novel agent cefiderocol. But most MBL producing isolates also produce extended spectrum beta-lactamases that will confer resistance to aztreonam if used alone. Hence, combining aztreonam with a BL-BLI beta-lactam inhibitor serves as a suitable alternative to polymyxin-based combination. You can cut the cost a lot. So genotypic platforms often pick up the presence of two carbapenemases in the same isolate. Usually in our hospitals, you will detect New Delhi metallo-beta-lactamases and OXA48 both together. So extrapolating from the above discussion, combination of aztreonam with ceftazidime avibactam. See, aztreonam will cover what? Aztreonam will cover your NDM, but as most NDM producing organisms also produce ESBL, you have to combine with some uh, avibactam, tazobactam, sulbactam. So that has to be combined. So combine aztreonam with ceftazidime avibactam. We will have synergistic effect as ceftazidime avibactam inactivates OXA48 carbapenemase, leaving aztreonam to act against NDM MBL. So, Acinetobacter carbapenem production in Acinetobacter species both by serine and metallo-beta-lactamases is widespread in hospital-acquired infections, resulting in extended drug resistance pathogens with virtually no treatment options. Mutations in porine channels and overexpression of efflux pumps also contribute to clinical resistance. Polymyxins are the mainstay of treatment for drug-resistant Acinetobacter species. Other drugs that often retain susceptibility to resistant isolates include minocycline, beta-lactamase inhibitor sulbactam. Even strains that are resistant to carbapenem sometimes retain in vitro susceptibility to sulbactam. I use sulbactam. Sulbactam helps a lot whenever Acinetobacter is there. So similarly, Pseudomonas species display intrinsic resistance to various antibiotics, ertapenem, tigecycline, chloramphenicol, and efficiently acquires resistance to other agents during treatment. So, what is the final philosophy where we are standing? Just try to understand microorganisms have existed on the planet battling the forces of nature far longer than any other life form. Humans came much later. So don't try to think that we can befool these microorganisms. The dynamic phenomena of resistance does not develop anew whenever we start antibiotic in our ICU. Antibiotic resistance is a pre-existing, preconceived marvel that has existed since prehistoric times, abundant in nature, ever evolving to outwit every existing drug and most likely every compound still to be invented. Our use, misuse only results in compounding the selection of resistant strains already existing in nature. The anticipation of some new agents that something new will come is therefore not a viable solution to the extended drug resistant crisis. The burden is on us to preserve the existing antimicrobials as a non renewable source, a powerful double edged weapon that undoubtedly saves lives, but at the same time has inconceivable ecological ramifications that compromise the very future of modern medicine. Thank you. Thank you.